Hi guys, welcome back to my channel. It's Dr. Shaw. I'm really sorry about all the upload schedules. I want to keep it real with you, and sometimes residency isn't smooth sailing. I know that's like the obvious, but here we go. Here we are. It sometimes gets really stressful and exhausting. I'm about to go into a month of night shift. I have a bunch of videos lined up. I just have not had time to make thumbnails and blah blah blah. But yeah, so I just wanted to check in with you guys and just to share a few thoughts that I had while I was on this previous block. I did make a vlog. It's not as, in my opinion, I guess it's not as in-depth as my ones from intern year, just mostly because we've been part of the hospitalist team and the level of responsibility and the amount of things that we've been doing has just increased so much. And just being in a small hospital, it's been a lot more difficult trying to film and show you guys an accurate view of what it's like day to day without compromising privacy and HIPAA. And that's very important to me because patients always come first. So I apologize for, I guess, the difference in the videos, but I really hope that you can still have an idea of what it's like day to day being a hospitalist in a rural hospital from my previous video. But so this video is going to be a little bit more, I would say, heavy, and I think it's something that's been weighing heavily on my mind for quite some time, and I think that is something that needs to be talked about, and it's usually not really talked about very much because it's just uncomfortable, and that is the realities of death and code status and CPR. I think that I'm hoping that making this video, it will help clear up some ideas of what it's like and what it actually means, because not many people know and not many people have this kind of conversation. So I just wanted to go through it with you guys. So basically, when we have a patient that is admitted to the hospital, it's standard practice, like you have to do this, is you have to ask code status. And I've had some patients that, sometimes get annoyed or they take it the wrong way, but it's truly not personal at all. We want to do what's right by the patient and respect their wishes. And if they're not in a position where they're able to accurately express their wishes or don't have formal documentation stating what their wishes would be, then we need to gather that information from the healthcare power of attorney, which is like the next person. So, I know those are things that people don't want to often think about, and it may not even come to that, right? Like, it's not necessary that it's going to be something that comes up in your admission, but it's something that needs to be talked about, and that is code status. So the first being do not resuscitate. What does that mean? So what that means, do not resuscitate, there are two major components to when it comes to resuscitation. One is ventilation and one is chest compressions. Some may say that you can't really, there's no point in doing one without the other, whatever, that's a whole separate thing that I'm not going to get into, but that's pretty much what it is. So if you're being asked about your code status, if you're saying that you're full code, that means in the event that you need to do chest compressions and your heart stops, in the event that your heart stops and you need us to do chest compressions, do we have permission to do so? And the next thing is intubation. If it becomes necessary that you need to have a tube put down into your lungs so that we can have help you breathe, is that something that you wish to happen? Some people do wish for it to happen and some people don't, and that's why it has to be asked. The thing is, the default knee-jerk response is I want to do everything possible within my power to save myself or my family member or whatever. A lot of times people don't exactly know what it really entails, so I just wanted to share that. Obviously, the whole purpose of resuscitation is to bring the person back in a best case scenario, but with it there are some significant risks. So one of the biggest ones that I think most people know about is if you're doing CPR, the pressure, what you're doing is you're using your compression, you're compressing the body to keep heart pumping blood throughout the body. So when you're doing that and you do it with the appropriate amount of force, there is a very strong possibility, and some would even say that if you're doing it properly, the ribs will break. So you have its own set of complications if you have broken ribs, in addition to all the other things that could be going on with you, if it could puncture a lung, that kind of stuff. If you've been without oxygen for however many minutes, that also has its own set of things that could happen when it comes to brain injury and things like that. So there's that. The same thing, intubation, it has its own risks and benefits and things like that. So I think it's important for people to realize what they're asking for, whatever it may be. If you want to be fully resuscitated, that's fine, as long as you're fully aware of exactly what that means and what is entailed when you are actively coding. And I mean, I understand, like, for very good reason, like, you wouldn't want a family member to see that because it is extremely traumatizing to watch. And it's kind of like, it is traumatizing to be involved in as well, but I think when it's a family member, it's even more so. So I kind of wanted to just share that, and I think it's something that everybody needs to talk about with their families, because it is an impossibly difficult situation to have to figure out and make those huge decisions, and it's something that you've never talked about, but those conversations are really difficult to have, and I completely understand that. Like, I've had that conversation with my family and my husband, just because you never know. That's it. You never know. Car accident, whatever, you never know, and that's a really huge burden to put on somebody else, or have your wishes written somewhere. So there's that's about the code status. And the reason I bring that up is because during my inpatient rotation this past month, it was challenging for many reasons. The obvious being that it was just difficult medicine and time commitment wise, but also just emotionally it was difficult. This past month was the first time that I actually was involved in a code. All of last year, I actually had never been a part of a code. It just never happened, not in my ICU rotation, not in my emergency medicine rotation. It just never happened, right? It's not one of those things that you can predict. I even had a procedures rotation where I rotated with the emergency response team, and it just never happened. So this past month was the first time that I was actually a part of it. And it was very, I don't even know, like, it's really hard to describe what you feel when you're in that moment. I would say it's a mixture of terror, adrenaline, and fear. Well, I mean, maybe for me, because it was like my, very first code, and it's just terrifying. Like, you want to do everything in your power to bring this person back to the best of your ability. And, sometimes it works, and sometimes it doesn't. And it's really difficult to grapple with that, because you always think, like, could I have done this better, or could I have done this faster, or whatever. But honestly, it is just to walk you through it a little bit. So basically, when you have someone that's coding, that means that they're essentially dead, especially if they don't have a pulse, intents and purposes, and you're trying to bring them back. The feeling when you're in that room and you're in that situation, it's just a very surreal feeling where you feel like you're fighting an unseen force. It's like this tug of war between you and your team, which is like all the health, like the nurses, the respiratory therapists, the anesthesiologist, like everybody, whoever, the emergency response team. Like, at our hospital, we don't have all that. Like, it's the doctors and the nurses pretty much, and like some we do have respiratory therapists and the emergency room physician, anesthesiologist. In this particular situation, the hospitalist was signed off on being able to do intubations, so I actually was able to intubate because of that, and because I had been trained to do so, obviously. But yeah, so you have this entire group of people that are playing this invisible game of tug of war against an unseen force that is trying to take this person away. And I don't know if that makes any sense to anybody, but that's what it feels like. You don't know if you're winning or losing. And you don't know until the very end, and you put 100% in. Like, doing chest compressions is honestly very physically demanding, and you are putting 100% on that line. And it is a feeling that it's difficult. It's really difficult, and it's especially difficult when you've been with that person, or when you've been with that patient for a while, and you've been taking care of them, and you grow attached to them, and it's really, really hard, especially when you don't win this invisible tug of war. I think the thing that I took away most from my experience being involved in the code and doing chest compressions and intubating is it just reinforced that you always have to fight. You fight, and you never give up, and you never give in, and you try your best and then if it doesn't work, it doesn't work. And I know that sounds like the most obvious thing in the world, but it just has a whole new meaning when it's a human that you're fighting for, a human life. Somebody's grandma, somebody's mom, somebody's grandpa, somebody's dad, somebody's brother, somebody's sister. Like, they are loved, and fighting in that moment just takes on a whole new meaning. And I think that it's also important to process how you're feeling. So this is kind of my way of processing it, I guess, because it does take its toll. And I think that's one of the hardest parts about residency is that, or inpatient medicine in general. But I say that this is the hardest part about residency because you're still learning how to do this. And it doesn't necessarily mean that it's easier later on, but perhaps you have developed the coping mechanisms to deal with it better, hopefully. But I think this is the hardest part about medicine and residency, that no one can really teach you, unfortunately, and it's just something that you have to get through. It's just that you never quite forget any of the patients that you lose. Like, they stick in your brain and they stick in your mind, and a part of you knows logically that you did everything that you could, but perhaps a smaller part of you, perhaps a less rational side of you, felt that, perhaps there was something more you could have done. And if you don't take time to process those feelings or talk about them, then it can get overwhelming. And so after we have situations like this, luckily for me, I really like my attendings, and I have close friends like in my residency program that I really get along with, and just friends in general that have been through it and like have been in the exact same position. So talking about that really helps. I think I really struggled with that during MICU, and it just came back, I guess, like this past month when I was on the hospital. And and being in a rural hospital, you don't have access to the same degree of resources, so there was more that was expected of us, which is fine, obviously, because that's what we're there for. But yeah, it was just a learning curve in terms of the medicine, but also in terms of how to handle those pressures and how to grieve the loss of a patient before you have to go on to the next one, because you do still have to see the next patient. You still have to go on. You still have to make sure that you're giving 100%. Maybe you just lost a patient. 2 minutes later, you still have to go see everybody else, and you have to provide them the best care because they are also very sick, and that can be hard. And I don't know, I'm hoping that it gets easier. Yeah, I'm hoping that it gets easier. I don't know. I don't have anything else to say to that. So far I guess it has gotten better. I didn't go cry in a supply closet, so that's good. After losing a patient this time last year, I totally did. So yeah, didn't cry in a supply closet. That's good, right? This is a little bit of a dark video, but that's the realities of residency. It's a reality of healthcare. It's a reality of life. And I think it's important to talk about it. If you're a resident that has felt this way, or a healthcare worker, or clinician, whatever, if anybody that's felt this way, it's okay to feel this way, and just comment down below or something and tell me how did you deal with it. All right, well, catch you guys later. Bye.